Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, and today we have a really interesting topic that we don't talk a lot about in our field, and we need to talk more. With me today is Dr. Rhonda Schwindt. She's an associate professor at the George Washington University School of Nursing, nationally certified psychiatric mental health nurse practitioner with an active clinical practice, with a specialty in LGBTQ+ health, trauma, and treatment-resistant mood disorders. So welcome, Rhonda.
Oh, thank you. And it's good to be here and to talk about, as you mentioned, a topic we don't talk often enough about, an important and interesting one.
Well, there's two issues, really. I don't think we talk about smoking cessation enough in our patients with mental illness, and we don't talk about LGBTQ+ issues enough, and certainly mental health issues there in this population. So now we're talking about both, I suppose.
I agree.
Is this a special problem in this population? Is it a bigger problem?
It is. In the LGBTQ+ population, the prevalence of the use of all tobacco products, so combustible and non-combustible, is significantly higher when compared to their counterparts, heterosexual and cisgender. And because of that, then they are disproportionately impacted by all of the tobacco-related diseases, and also then a shortened lifespan because of that increase in prevalence.
Right. What is the thinking around why that is? I mean, it's a very general question, I realize, but obviously I have some thoughts, but what is the sense of why this is?
Well, we've known for a long time what's contributing to that higher prevalence. I think where we struggle is, what can be done about it. That's where I think we need to focus more of our efforts. One of the things that we know is that exposure to discriminatory experiences based on sexual orientation and gender identity have a huge downstream effect on those individuals. And one of the downstream effects is an increase in prevalence of all substance use disorders, including tobacco.
That makes sense.
And then when you add on top of that, lack of access to care, and then even when individuals are able to access that care, being able to find providers, both psychiatric and in other disciplines that are affirming and understand LGBTQ health is another barrier, and to try to overcome both of those can be really difficult. But despite all of that, the good news is that LGBTQ people have the same level of intention and desire to quit, and their quit rates are comparable to other subpopulations of smokers, if they're able to access that treatment.
That's fascinating. That is good news. You're right. Well, I can imagine there are many factors at work here. Certainly the stress, as you said. We know that smoking increases, for instance, dopamine. And so the dopamine is positive for the mood. It's calming, although unfortunately, the nicotine effect is transient.
Exactly.
I wonder, is there a social component? Do people find comfort with others? Do they smoke together? Is there anything like that?
Oh, absolutely. That's another important component that also traces back to the idea of gender and sexual minority stress. So because so many individuals are marginalized by society, the need for a community in which to belong, to be accepted for who you are and who you choose to be is of paramount importance. And so many times, you have a community that has a historically high use of tobacco products, and because we're not doing enough to combat that,
Right.
You add that on top of the fact that, smoking for many people is a social behavior.
Exactly. That's what I'm thinking.
It's, you're maybe at a place that you don't feel particularly comfortable. You walk outside to smoke. One of your peers is also out there smoking, and it gives you that camaraderie that you may not find somewhere else.
Yeah.
Had someone tell me once that I was working with that said, right at the time that I had been rejected by my own family, and I then discovered my new queer family, they all smoked. And it made me feel better. I felt more included if I also did.
Yes, that's exactly what I was wondering.
Which makes a lot of sense.
It does. It certainly does. Yeah, you sometimes see groups of people smoking together or vaping together, for instance, that kind of thing. I can also imagine, my understanding is that rates of mental health illness in general, depression and anxiety, for instance, are higher in this population. And we know that rates of smoking are higher amongst people with depression, bipolar, schizophrenia, anxiety. And there may be biologic reasons, as I said, that have to do with dopamine dysregulation and whatnot. So I assume that may be related to this as well, the rates of mental issues.
It's another contributing, or can be another contributing factor. And I think that is really grounded in the concept or construct of intersectionality as well. So if you think about what that means, so in individuals' social and cultural identities come together and most often collide. And it's that collision that results in healthcare inequities, health inequities, social injustices.
Absolutely.
And ultimately marginalization.
Yeah.
So, and then if you have an individual, we know that the more marginalized identities that they hold, the more likely they are to experience the inequities. And then if you add on top of that a history of or currently being treated for a psychiatric illness, it's just another pile on.
Right.
Because there's also marginalization, stigma associated with mental illness.
That's right.
Now, the reason that our LGBTQI folks have a higher rate of mental illness is the same reason why there is a higher prevalence of the use of tobacco products.
Okay.
So much of the depression and anxiety and substance use is centered around that marginalization, that stigmatization, the lack of acceptance of who they are based on one of their identities.
Exactly. Yeah, I can just imagine what a hit this is to somebody's self-esteem and, what that entails then, the things that flow from the low self-esteem, feeling like, I don't deserve better, I don't deserve this, it just becomes this negative cycle.
Oh, yeah. Especially if you can imagine that starts at the age of, 3 and 4.
Yeah, you already know you're different. Something's different about me.
And you have, and we know that a supportive family is a very, very strong protective factor. But if that's not there,
then
then
like you said, you have to find a family. Then they try to find family and community, elsewhere. Yeah. I can imagine too that there's significant barriers. You mentioned earlier, of course, one obvious barrier is finding a provider who's knowledgeable in this area and who's certainly accepting, as you said. What other kinds of barriers do these folks face when trying to quit smoking?
Well, and I think you started off with a really important one, and it expands beyond just the individual that you may see in, face-to-face in an office or in an exam room. It starts from the moment someone makes an attempt to schedule an appointment. Right? Maybe it's online and they go to fill out what their gender identity is and there's not an option.
Yep.
Or they check in at that, front desk, so to speak, and their gender identity or their sexual orientation is questioned. So that exposure to those kinds of events is one of the main reasons it can keep people from even wanting to go in, and then not knowing what they're going to find when they get there. Is this someone that's going to be comfortable with who I am? So that's a huge barrier. And And then the treatment interventions that we do have, the behavioral interventions to help people quit using tobacco products, are often not reflective of the lived experiences of the people within the community.
Mm-hmm.
So it's especially important for those of us like myself who are allies to understand that when we're providing care, and if we're developing any kind of programming or tobacco programming, it has to be done with people of the community that understand what it is that they're living every day.
Yeah. You just taught me a great word. I love that. Say you're an ally. I've always said I don't necessarily have to have schizophrenia to treat schizophrenia. I don't have to have alcohol use disorder to treat it. So I love what you said as someone who's an ally. That's
and
nice
acknowledging that we are, right?
Mm-hmm.
That we aren't trying to represent that community. What we're trying to do is to work with them, collaborate with them, not without them, in order to provide that affirming care that they need in order to quit and to be successful at that.
That's another great term you just said, affirming care. I think the terminology is very important here, and I think for our audience it's really helpful to hear. Affirming care, to be an ally, be empathic, these kinds of things, and to involve someone. Lately at NEI in particular, we've been talking a lot about shared decision making and involving the person in their own treatment plan and their own care. And so I think really understanding the person's lived experience is part of that.
Absolutely. And taking the time to figure out what is that for them, because, the LGBTQ plus community is a big community in and of itself, but there's diversity within that community.
It's very diverse. That's right.
Both within the subgroups, but also at the individual level. And so really getting to know that person and saying, what do you need? What's important to you? People are not going to call, for example, a tobacco quit line if when they do, they're going to be questioned when they give their name and someone doesn't think the pitch and tone of their voice matches that.
Yep, exactly.
Who wants to do that?
That's true.
Yeah. Who wants to, nobody wants to have to be exposed to that. So it's
it's
understanding that individual and, okay, how can we match you with the kind of care that you really need?
This is really interesting because I think a lot of these things are things that we take for granted or we don't consider. So it's really trying to put yourself in the other person's shoes or at least ask them what it's like. There's another thing we haven't talked about, and I was sort of surprised to learn this, that tobacco companies have historically targeted this community through advertising and sponsorships. Can you speak a little more about that? Because that's another barrier we're facing here.
They most definitely have, and other marginalized communities as well. And I encourage everyone to take some time and kind of go back and look at the historical perspective of that to really understand when it all started. And one of the most startling was back in the mid-1990s, once the tobacco companies were sued by the Attorney General and all of their internal documents were exposed, they started what they called Project Scum. And Project Scum was to specifically target the LGBTQ plus community with very targeted marketing because they wanted to increase their rate of using tobacco.
Wow. They saw this as a market.
They did. And continue to do that in ways of, we're in Pride Month. So during Pride, putting up posters that link tobacco products with being prideful.
Oh, my goodness.
Using the rainbow colors on posters.
Yeah.
Sponsoring post-Pride parties.
Wow. I had no idea.
Posting positive, supportive, affirming comments on Twitter, right? Because then they're perceived as being, wow, they're with us. When what they're really wanting to do is to find an audience, right, to keep using products. And youth are particularly susceptible to that exposure to, and they've they've recently changed their strategies, which is intriguing in some ways. That before they were really targeting demographics, and now they're really doing a more granular approach, and they're looking at like psychographics. So they're thinking again about what gets people, what draws them in psychologically. Well, words, colors, what attracts people to us. Kind of goes back to those times with Joe Camel and the cute little cartoon camel.
Yes, exactly. Right.
Kids thought it was a cartoon character.
That's
like,
right.
Well, this is cool.
That's right. Yeah.
So it's something we still very much need to be combating.
Yeah. Okay. Well, this is a whole nother layer here. This, I guess, societal layer I didn't thought about here.
Yes, absolutely.
Layer. Okay. Now, you mentioned, so there's obviously various forms of treatment, as we all know, for smoking cessation that include pharmacologic and non-pharmacologic. Let's start with non-pharmacologic. You mentioned some behavioral interventions. What kinds of things are effective in this community?
Well, many of the same behavioral interventions that are effective across populations are also effective for members of the LGBTQ plus community. What we have found out is that sometimes the intensity needs to be upped in the frequency.
Okay.
So more frequent contact, more frequent, perhaps, pro-quitting text messages, more opportunities to interact with either a lay, a counselor or their provider to check in on how they're doing.
Sure.
But in terms of the actual intervention themselves is not necessarily different. But the other thing is that culturally informed approach.
Yeah, exactly. So it has to be tailored. Yeah.
Right. Where do they need us to come and provide that treatment? What is most convenient to them? Do they want it to be online? Is that more comfortable?
Yeah.
They want their peers involved. They want to be able to look at someone across the room in a group therapy and know they've been there, done that.
Yes. Yes. I was going to ask about that.
Doesn't mean we can't be involved as allies. It just means that we've got to involve them.
Yeah. I was going to ask if peer support is used and if it's helpful, and it sounds like it is.
I think it's absolutely vital because the people that they are interacting with, not only on a daily basis, but just in general, own members of their community, they need to have that because they intimately know what they're facing. They can share experiences and get that empathy that those of us who don't experience it can't provide. And we've got to also have more role models who are out there doing, pro-quitting campaigns and showing that you can be just as cool and not smoking. I mean, that's still a thing, even now.
I know. Yeah, I've noticed that, in Hollywood and TV shows, it's cool people still smoke. I've noticed that, it's
yes.
The cool characters still smoke. It's funny.
They still do.
Yeah. Okay. So what about the difference between individual and group types of interventions? And then we'll talk about online and digital in a second as a separate thing, but just for the sake of talking about that.
In terms of individual, I think looking at it from the perspective of both pharmacological and non-pharmacological. So when you think of the non-pharmacological interventions, it's very similar to what we talked about before, is really spending the time getting to know the underlying factors that are contributing to that individual's decision to either continue using tobacco or wanting to stop using tobacco. Is it stress for them? Is that someone in a recent qualitative study that we did, several individuals described stress as a superbug.
Interesting.
And that, you can't expect us or me to stop smoking if you don't figure out how to deal with the stress that I experience on a daily basis. You have to help me with that before I can or as I am attempting to quit. So what's going on with that person?
Well, so now you're talking about healthier stress reduction techniques.
Absolutely.
Ways to cope with stress, besides just reaching for a cigarette. It's learning other skills.
It's learning other skills. And then what their exposure to stress was going to be very different, most likely, than, people that are not a member of the community.
Right.
And so how can we help them cope with that? What are some strategies, or where can we help them find the support that they need? If it's a religious community, you need to have a list of communities in your area that are known to be affirming. Where can you send them if they need that extra spiritual support?
Absolutely. Yeah. Okay, and I'm imagining that group counseling or group therapy here is very effective as well, as we talked about. I mean, the power of peers and role models.
Oh, I think it is for some individuals, maybe not as much for
not
others.
Everybody. Yeah.
And what I love to see when I go to different pride parades, I'm hoping to be able to go to the one in Chicago this weekend, is that you see, and even starting to see more like pro-quitting groups that are there. And that are even walking through the crowd, and opportunities to engage with people and talk to them. So it's a sort of an informal group therapy.
That is interesting. Yeah.
Sometimes for, perhaps not for everybody, some transgender or gender diverse individuals may not be comfortable in a group.
Yeah, I understand.
And so they may feel more comfortable, for example, with a tobacco quit line. And so it's understanding, when does that group work for that person, and when is it too much? Or somebody with anxiety. One of the things I love about telehealth is I hear from my patients all the time that are highly anxious. It's like it only increased their anxiety to try to get through traffic, get into the office, sit in a waiting room.
Yeah, of course.
They can be in the comfort of their, own living room.
Yes.
Same kind of thing.
Yeah, that makes sense. So I imagine, though, that there are data on the effectiveness of these interventions. What are some of the data that speak to the effectiveness of these kinds of interventions?
They work.
Okay.
We know that for the larger group, the LGBTQ plus group, that culturally tailored interventions work to help people be successful. Now, generally, we recommend that there's the pharmacological interventions as well for those that it's appropriate for.
Yeah.
For our transgender and gender diverse community, it's a little bit harder because when we do research, that subpopulation is subsumed into the larger group. So when we look at data many times, it doesn't separate out.
Okay.
What we do know, what data that we do have, it tells us that a culturally informed approach will also be effective and has been effective for that subgroup of individuals as well.
Yeah.
And as I mentioned in the beginning, their quit rates are comparable.
That's very encouraging.
Both those with and without mental illness.
Yeah. Let's talk a little bit about, are there any digital interventions and online kinds of interventions? Well, telehealth is another intervention in my mind. But, that would be, we're talking sometimes now about synchronous interventions, which would be telehealth when you're in front of the patient, and asynchronous, interventions. It's not face-to-face. So what kinds of options are there for maybe more asynchronous kinds of things?
Well, a lot of programs now have been developed where the individual can sign up, where they receive those pro-quitting text messages every day. It's very similar to, insurance companies that will set up programs to help people lose weight. And they have access to digital, web-based materials, and they can receive emails and text messages that give them tips for the day. That can range, the other. So I think for a lot of people, the ability to sit at their own desk and go online and say, oh, I can watch a video here and hear other people's stories about quitting. I can, go to the CDC website and I can read about it, and they'll send me to places that I can go to get more information, is vital for individuals, particularly, if they have transportation issues, for example.
Yes.
Difficult work schedule. I think we're going to see more and more. I think the pandemic, one of the things it taught us is that it works.
Yep, that's true. Now, you've mentioned, I'm thinking about resources. You just mentioned National Institute of Mental Health's website, of course. Are there other resources here we can recommend?
Absolutely. I mean, I would go to the CDC, National Institute of Mental Health. University of California, San Francisco has a wonderful leadership center related to tobacco cessation. Lots of resources available.
Wow,
Fenway Health in Boston is one of the leading places that you can go for information about LGBTQ plus health in general. And then also information and resources for tobacco use and tobacco use dependence can be really helpful. And, the Trevor Project for LGBTQ youth is huge.
Yes.
And Human Rights Campaign has, a lot of resources available to point people in the right direction, can be very helpful as well.
Wow, thank you. That is a great list of really valuable.
There's a lot of good ones out there. It's finding them and knowing that they're there.
Yeah, that's great. Well, I'm sitting here thinking about people who are in a more rural community or, farther out. It's great to have these kinds of resources because it's going to be hard to find something in face-to-face locally.
Very difficult.
Yeah. All right, let's shift gears, if we could, and talk about the pharmacologic interventions.
Okay.
And how to tailor them or the effectiveness in this community.
Well, the pharmacological interventions are the same, regardless of population. So it's nicotine replacement products, Zyban, varenicline are our primary go-tos to help people quit. And their effectiveness is not different based on someone's sexual orientation or gender identity. So you're going to prescribe in the same way that you would for any other individual. I think where we run into trouble is something that you mentioned at the very beginning, is that, we kind of had two separate issues going on here. We have the increased prevalence, but we also have the problem of providers really across disciplines being trained in and feeling comfortable with tobacco cessation counseling and treatment.
Yeah, that's true.
And there's a lot of myths surrounding that. For example, well, I can't worry about it now because I've got there are too many other problems we need to be focused on. I've got to stabilize this first. Then I can think about that. Well,
I understand.
The evidence doesn't support that approach.
Right.
And not only does the evidence not support waiting, but then when people wait, it often forget to go back to it and say, let's not forget that we want to talk about your tobacco use. And data also shows us that individuals who are living with a mental illness as a group in and of themselves are less likely to be prescribed pharmacological agents to help them quit smoking.
Now that's interesting. I didn't know that.
And a lot of it appears to be, from what we know right now, a lack of comfort on the on the fact of the provider. Not only related to just doing the cessation counseling itself, but also fear of, well, what's going to happen if I prescribe it to them? Is it going to exacerbate their illness?
Right. Well, in the case of, you mentioned Zyban, which is bupropion, of course, I wouldn't prescribe that to a patient with bipolar disorder, or certainly one who's not on adequate mood stabilization or an atypical antipsychotic. So that one makes sense. but the others not as much. Yeah. Interesting.
Well, and the evidence really does show us that across the board, nicotine replacement, Zyban, and varenicline have not been associated with significant exacerbation of psychiatric symptoms.
Okay,
across
Rhonda, I
diagnostic
forgot.
groups. Yeah.
Yes,
So
I forgot.
Yeah.
I forgot about that warning. For a while, varenicline had this warning about depression and suicidality. I totally forgot about that.
And it's been gone for,
Yeah.
I think it was like 2016 when that was removed. And the same for Zyban. Now, if someone is concerned and they're like, I don't want to prescribe it for them because they have a history of, maybe hypomania that's medication induced and you're a little worried about the activating effects, then go with varenicline.
Yeah, exactly.
And varenicline compared to nicotine replacement therapy and compared to Zyban tends to be more effective.
Oh, I didn't know that.
Although others are effective as well. The key is that the rate of success increases significantly if the individual is receiving pharmacological intervention.
Coupled with non-pharmacological, I imagine. It's a package.
Packaged together, just like you don't want to use just one nicotine replacement product. You need to be using two.
I didn't know that either.
Yeah, you got to use both. So you need to have your patch, as well as lozenge for those cravings. And
I didn't realize that. Is that the standard now to use two?
That's the standard.
Oh,
you need
goodness.
both.
I did not know that.
Just like you need both pharmacological and non-pharmacological.
Yeah,
you gotta do both of those.
Right.
And not forget about varenicline.
Okay.
In fear that.
Yeah. I think you're right. I think a lot of providers certainly in my generation remember when varenicline came out in those early days, and I sort of still have that impression in my head. You're right about the suicide risk. The other thing that occurs to me. Go ahead. Yeah.
Oh, I was just going to say, what I try to do, is not discount sort of the discomfort and the fear, but try to kind of normalize it in the sense when you think about any of the medications that we prescribed. They all come with associated risk profile and side effect profile.
Of course.
And we design our care based upon that. How soon do they need to come back in? What do they need to monitor for? Varenicline is no different.
Right.
Just like we're going to assess for certain side effects with an atypical antipsychotic. If we have somebody on varenicline, and we're concerned, maybe they have a history of active suicide ideation, then we monitor for that more closely. We let them know. We have a safety plan.
Got it.
What we don't want to do is to not provide a known effective treatment that we know is one of the most important things that individual could do, which is to quit using tobacco to improve their health. We don't want to keep that from people.
Right. I like to say you don't want to make the decision for them. And
Absolutely.
Again, it's shared decision making, isn't it? It's talking about the pros and cons.
Yeah.
The other thing I'm thinking is if there is a concurrent mental illness, and I guess my bias is there often is, I'll just be honest. And if there is, I would imagine effective treatment of that condition is also critical, and it's not an either or here. It's kind of all of the above. Am I right on that?
Absolutely. Yes, you don't want it to be an either or.
Or a sequential kind of thing, yeah.
Right. So, yes, there are times if an individual comes in for an initial evaluation and they are in crisis, right? Mm-hmm. You make a decision about do they need to be in the hospital or can I tap down this mania as an outpatient? And yes, in those situations, I'm not going to be thinking I'm going to, need to prescribe them varenicline.
Right.
But what I do need to do is to really make sure that I follow up on that because, many of the medications that we are going to prescribe are impacted by cigarette smoking, by combustible products. The metabolism is affected. Then the person needs more olanzapine, right?
That's right.
Then they get more side effects. Then they don't take their meds. That if they weren't smoking, they could be on a lower dose.
Right. What you're referring to is that smoking, and it's not the nicotine. It's like you said, it's the combustible. It's burning. My friend Jonathan Meyer taught me it's burning organic matter. Actually,
yes.
It is. It releases a chemical called aerocarbons, and those induce cytochrome P450-1A2, CYP1A2. And as you mentioned, olanzapine and clozapine and asenapine, all three of those are metabolized by CYP1A2. And there are others that are as well. And I think we also have to mention marijuana just real quickly. If you smoke marijuana, you actually are creating hundreds of cannabinoids. And we're learning more and more that cannabinoids also interfere with various cytochrome P450 enzymes. So I'm glad you brought up the pharmacokinetic aspect of this. It is a real issue to think about.
Well, I learned it in NEI. And Dr. Stahl, when I teach my students, we use his textbook. So, and you've always got to take
from
that.
Each other.
Yeah, absolutely. It's wonderful.
Yeah,
it's wonderful.
Well, I learned about marijuana and cytochrome P450-3A4 from my friend Roger McIntyre. I learned about the aerocarbons from Jonathan Meyer, and we all learn from Stahl. So
and then you share it so other people know it too. Absolutely,
that's right.
And it's difficult because it brings up the whole idea of, do we do harm reduction strategies?
Well, now that's interesting. Can you speak to that? This is not necessarily an all or none thing, right? Sometimes it's about harm reduction. So, tell me about that.
It's probably one of the most controversial topics in the tobacco product landscape, so to speak.
Okay.
If you want to get into a heated debate, bring up harm reduction strategies because it's historically been very divisive, and really for good reasons, because when the idea first came out back in the 1960s that when the Surgeon General first released and said, hey, cigarettes are bad for you, well, the tobacco companies, they needed a strategy. So they went about marketing, let's just do ultralight or light cigarettes, and because it's better for you, and you'll be exposed to less tar. And over time, the research showed that that wasn't true.
Yeah.
So what's kind of happened is that history has followed us into the tobacco community in terms of, when you start hearing, e-cigarettes, right? They're not combustible.
Yes. Right.
So they're being exposed less to those products that you mentioned that kind of ignite when you light something like a cigar or a cigarette. So let's try that.
Right.
And it's been very hard to achieve consensus on what to do. But I think there's some general tips that help people, I think, with this. One is that we have to keep in mind that ultimately, yes, our ultimate goal is total abstinence.
Right. Has to be.
Right. But there are acceptable alternative ways that can complement our approaches to helping people quit.
Okay.
Especially for those people who simply aren't willing for whatever reason or have been unable to do so. So the question, that we have to ask ourselves is, what can we do for those individuals rather than writing them off and just forgetting about it and saying, okay, I've tried, you're not going to quit.
Right.
Which would be an ethical discussion in and of itself. It's what can we do to move them lower on that risk continuum?
Okay.
Right. So if you think about combustibles being that high on the continuum, being the highest, can we move them down? Can we get them on something that is less if they're not ready yet? to quit, or they're struggling to do that. And so I try to keep that in mind when I try to help people, is that, there are ways, we believe right now, with e-cigarettes, with alternative nicotine delivery systems, that we can reduce that exposure.
Okay.
What we have to be careful with a couple of things, though. One is the struggle has been that as we focus on harm reduction strategies and we're promoting that, are we in fact setting up a whole new generation of our young people to nicotine addiction?
Yeah.
So while you're trying to help one population of smokers, are you harming the other one? So can we maximize the benefits to those who are current smokers, while at the same time minimize the impact on our youth who may begin to start smoking?
Okay.
Other problem that we run into is very, very few people who use tobacco products use one product.
Okay.
So what you often can end up with is someone who is using e-cigarettes, say in situations where they can't smoke. Maybe at work, or, there's been a smoking ban. But they haven't given up the cigarettes.
Right.
Not a good scenario. So it's also educating our patients that, okay, let's do harm reduction, but we want to get you to the point where you're either not smoking or you're only using one alternative tobacco delivery system, not supplementing it, not using the snuff plus vaping when you want to go and hang out with your friends that also smoke. And then it's a tough one. It's a challenging a lot of things you have to balance.
Yeah. So vaping, you're saying, still carries risk. What are the risks?
It's really interesting. During the COVID pandemic, you may recall that there were case studies that were coming out, especially among younger individuals who had developed COVID, who were vapors, who vaped.
Right.
And they were having more serious COVID reaction and more difficulty getting out of the hospital. And it was linked to the oils in vaping. Now, interestingly enough, some of the new research that's come out is that it actually was connected more to those who were vaping products containing THC.
Oh, interesting.
Not necessarily the commercially marketed e-cigarettes.
Right. Interesting.
So, as you know, we always have to be careful about what we are, how we're reading different research data, not just sort of that little ticket, the little tickers at the bottom of your news show, and you're like, oh my gosh, that's a headline. That must have been what happened. Oh, no, we have to take a little bit of a deeper dive.
Yeah. I teach residents. I always teach them to read scientific literature critically. Not just
very much,
not just read the conclusion and accept it. You have to understand.
And who sponsored the research?
Well, who sponsored is always important. Sure.
Yes.
Sure.
Yeah.
Sure.
But on the other hand, I do try to tell when my patients ask me, listen, the bottom line is if you don't feel like you're either not ready to quit, you don't think you can quit, you've tried to quit, it wasn't successful, then switching to an e-cigarette can reduce the health risk.
Okay. All right.
And, but using both products will not.
Right. So in a sense, you're substituting one addiction for another, I suppose? And
in some respects,
I mean, you could also make the case that nicotine replacement therapies are sort of doing that. Although the goal there is to taper them off gradually, right?
Right, because in and of itself, nicotine in and of itself is not what we're concerned about.
Okay.
what we're concerned about is, especially with the combustibles, is all the other things that you're inhaling while you're smoking.
Right.
And that, and one of the things that they found when the tobacco companies, back in the 60s, early 70s, started producing those light or ultra light cigarettes, well, people weren't as satisfied. So they either smoked more, which then increased the risk further, or for the ones that had, certain filters on them that supposedly filtered out more, they would just close up that filter because they weren't getting satisfied by what they were experiencing. So, so that is that.
There were also additives, I believe.
Oh, absolutely.
Some chemicals and things were added, and flavorings, and who knows what else.
And flavorings, and so it's keeping in mind that yes, it's that continuum that they do have nicotine in them. You're still going to be exposed to nicotine. However, are we appreciably decreasing your chance for various cancers, cardiovascular disease? And I think the answer is yes, we are. We just got to be careful with how we talk about that for our young people, that, this is safe. I think I'll just start it.
Right.
Is it? And it can be a gateway to other
that's
nicotine
exactly
products.
Right. I have to tell you a quick story. I remember working with someone who had cocaine use disorder years ago, and they were in sobriety, and what this gentleman said to me was, kicking the cocaine was tough, but kicking cigarettes is impossible. He couldn't stop smoking. And so the point is, this is highly addictive. The fastest way to get something into your brain is actually inhalation. It's not intravenous. So it's an incredibly effective way to get a drug to your brain, which causes a little bit of a buzz. It gives you that bang. So unfortunately, smoking is a very efficient delivery system.
It very much is, and it's highly, highly addictive.
Yes.
And so I think making sure that we don't lose our empathy for people who, we may look over and somebody's smoking and we'll think, really? What are you doing?
Yes.
You don't know by now that's not good. Well,
everybody knows that. That's been my experience with all people with substance use disorders. They all know that. I think there's two things at work here. One is the physiologic addiction, if you will, the physiologic high, or I call it self-medication. But the other is what we talked about before. There's a ritual to it. There's a societal aspect to it. There may be group and peer acceptance. So we're really battling a lot of fronts here.
Associations, with I go meet my friends for a drink on a Friday night, and I always smoke when I have a drink, or what am I going to do with my hands when I'm driving in the car?
Yes, right, something like that.
What do I do? What do I do now? And then, nicotine's it's a pretty conniving little thing because,
it is.
Its half-life is really short. So
very short.
I can remember so many times I'd run into colleagues in the elevator, and they would be kind of jittery and I'm just so stressed out, and I'm so stressed out. I got to go have a cigarette. And on the inside, I'm thinking, are you stressed out or are you going through withdrawal? Because it happens fast. So then they go out and they have that next cigarette. It gets reinforced. They feel better.
That's right.
Did that make them feel better, or did just get rid of that jitteriness that they were experiencing?
That's right. They're treating the withdrawal. It turns out that nicotinic muscarinic receptors desensitize very quickly. They're ion channel receptors. And muscarinic cholinergic, which are G protein coupled, are much slower. So that's part of the problem. They desensitize very quickly. So you get a bang, but then it goes away in a sense, and then you have to keep doing that.
Then you have to reinforce it again. You're like, now I gotta go back out and have that other one, and it makes it very challenging to help people. And I feel like our responsibility, our moral and ethical responsibility, is to not give up.
I agree with you. And there's research from the alcohol use field that they did a very interesting study. I think this was actually in the primary care market, primary care, where they had people with alcohol use disorder, and they had two groups. One where the clinician talked to them about it, and the other where they didn't. And it turned out that abstinence rates were not that different after a year, but after several years, the group where the person was talked to, they had much higher quit rates. And when they interviewed them, they said, well, they talked to me about it, and I thought about it, and I knew, and eventually I did it. But the other group said, well, they didn't bring it up, so I guess they thought it wasn't important.
Yes.
So I didn't think it's sort of like colluding with the patient, right? With their denial.
Well, and what we learned recently too, and then when we were conducting our qualitative study and we were interviewing, doing individual interviews with individuals who identified as transgender or gender diverse, we were asking them questions like, what helped you quit? What's kept you, from doing that?
Right.
And one of the things that came out consistently, and then of course when we did our discussion, it was consistent with existing literature that those individuals whose provider brought it up repeatedly and said, hey, I know the last time we talked, you said you weren't ready to quit.
Yes.
How you feeling now?
Yes.
Okay with you if I bring it up at our next visit? We're more likely to quit. Now, the reason in this particular group, and always knowing that qualitative, you can't really generalize it to everybody, but within these groups of people that we interviewed, what it communicated to them was, well, if they think I'm worth it,
yes,
maybe I am.
Yes.
Maybe I am worth, because we also found a sort of a passive suicidality, a desire to hasten death in this group.
Okay. I was wondering about that.
And it was very profound. And several said, why would I want to live longer in a world that reminds me every single day, several times today, that I'm not worthy and I'm not wanted and that people want to hurt me. So why would I want to do anything to make myself healthier and live 10 more years?
Exactly.
And it's not always necessarily a conscious thing. And so it's when you have somebody that says, I know you're struggling. I hear you saying you've had 3 or 4 quit attempts and they didn't work. I just want you to know that I'm here when you're ready and I'd like to keep talking.
Yes.
Can make a world of difference to that individual.
Well, I like to say, too, you shouldn't feel the pressure to close the deal the first time you bring it up. You're starting a conversation, right? Because I think sometimes we do. We feel like, they have to take what I'm saying as the gospel or something. Don't they know how smart I am or something?
That's right. Yeah. Why aren't they doing what I... Yeah.
Yes. And
if you think about it, it's really legit for somebody to say, you know what? I just got out of the hospital. I'm just trying to figure out how to get back to work. Now's not the time.
Right.
I get that.
I do too. But I think the idea of starting a conversation, and I love what you said about communicating the worth of the person, and that you're there and you're going to keep supporting them. You're not going to give up on them. I like that kind of thinking. So that's exactly the point I was making earlier with the alcohol thing.
I mean, how many of us really don't have habits that we need to change? I mean, who is walking amongst us, that...
Show me a piece of chocolate and I'll show you my willpower.
Well, a piece. Show me a bag of M&Ms and all. Yes. So
exactly. Of course.
You're right.
We all have that. And
we all have that.
We all know we need to exercise more and eat better diet and all of that. But I think the point, though, is that we're talking about something that is really toxic and really addictive, if you will. I hesitate to use the word addiction. I know that that's also a buzzword. But something that is very hard to quit. And I think we have to be sensitive to that, as you said. And I think that people who've had attempts to quit, they should be congratulated and supported that they actually tried.
Oh, absolutely.
And let's build on that. It's like we're starting again, it's more of a process than something that just happens, bang, is how it seems to me.
Well, and if they do tell you, we know that there's no safe level of smoking, right?
Yes.
There just isn't.
Yeah. Okay.
12 cigarettes is not going to make you less at risk than 16 or 20. But when you have somebody that says, I've been working at it and I'm down to 10 cigarettes a day. Well, that can build
definitely.
Confidence.
Absolutely.
That can build, they are heading in that right direction. And so
Absolutely.
what do we need to
Absolutely.
do to get them to yes?
Absolutely.
As opposed to saying...
Well, I think another wrinkle to this, in this community in particular, you're talking about people who've experienced a lot of negativity, a lot of negative feedback, in many cases failure. And so, yes, we should celebrate little victories, and we should we can build on positives more. I think it's even more of an issue here in this community that we're talking about.
Oh, absolutely, because they do every day live in a world where somewhere, multiple places generally, they are being told that it would be preferable if they didn't exist.
Right. Or if they weren't the way they were, somehow.
Because they've made that choice and they shouldn't be that way.
Yeah, it's a choice. That cracks me up.
Absolutely. And then we're going to make it even more difficult. We certainly have to be the group that doesn't do that. We're supposed to be the ones that bolster. And we have to, I often think, and I think it was one of the questions that you had sent me or that we had talked about was, what do we need to do? What is our responsibility? How do we actually, this is all wonderful information, but what are we supposed to do with it? And yes, do more tobacco counseling, learn how to do it. We need to be training people to do that. We need to be training our providers long before they enter into practice about affirming care. What does an affirming provider look like? Are they really just another patient? No.
Right. No.
They aren't just another patient. And so no one is. How do we address unique needs?
Of course.
But then even a step further about really spending some significant time in self-reflection and asking, what do I need to do individually and what do we as a profession need to do collectively to address the inequities, to address the healthcare inequities, the social injustices? What role can we play, no matter how small or how, what can we do because we know that that's impacting the people that we care for? And what do we need to do to work with them to make sure that happens? And we all should be concerned that our education system pumps out all of us, nurse practitioners, psychiatrists, primary care providers, without a clue about what it even means to be affirming.
I agree.
And, our patients are not our teachers, right? We learn from them.
Well, they can be. Yes.
We can learn from them.
We can learn from them, but that doesn't mean they have to be our teacher. I see what you're saying. Yeah.
Yeah. Can you imagine if you went in and you said, well, I think you have bipolar disorder, but I don't really know what that is. But hold on, or you tell me what. But the number of LGBTQ people that go in and people will say, well, what do you mean you identify as non-binary? Well, it's not their responsibility to teach you what non-binary means. It's your responsibility to learn.
I see.
Right?
Yep.
Now, it doesn't mean that after you have provided care that you're not like, wow, they taught me a lot. But they should be able to know that when their provider walks in the room, they're prepared. Now, if you really don't know, if someone says something, for example, well, I'm pansexual, just simply saying, tell me what that means for you.
That's a nice way. That's a nice technique. I like that. Yeah.
Share with me what that means. But too many times, we want them to be the token, transgender patient for us. And I know where if a short story is someone that we interviewed, and he said, I went in to get my teeth cleaned, and I asked him at the front desk to change my name. And because they had recently had their legal documents changed. They did. But then as soon as they went back to get the teeth cleaned, he goes, the whole rest of the visit was all about the fact that I was transgender. And they either wanted to prove to me how uber accepting they were, or they wanted to ask me all the questions that they've always wanted to know the answer to.
Right.
I just really wanted to have his teeth cleaned. He wasn't interested in being their token trans patient.
I understand. Right. So he wanted to just get his teeth cleaned. He didn't want to be the token. So we can overdo this a little bit too. There's still a balance in this, it seems like.
Yeah. I mean, learn from them, but educate yourself, which is what we're doing.
Yes, that's a wonderful place to end. Unfortunately, Rhonda, we're running out of time. This has been a wonderful conversation. I learned a tremendous amount. I hope our audience did too. I'm sure they did. And I particularly like how we ended with the kinds of responsibility we have as providers to look in the mirror and to educate ourselves as we try to keep up learning about all the developments in our field.
Absolutely.
And thank you once again. And thank you once again for those terrific resources you mentioned earlier. And also for just the hope, the positivity, the sense that treatment can be effective. We can help these folks. Hope is part of what we provide. I really believe that. What do you think?
I absolutely agree. And we've got to stay in their corner, no matter how challenging it may become. And if we face a situation we can't manage, we find them somewhere that we can.
Right.
If we need somebody that is more of an expert.
That's right.
But
get help.
All of us are capable of learning tobacco cessation counseling and treatment and affirming care and not throwing up our hands and giving up, which I don't think any of us do intentionally. I think it's just a lot of things to focus on.
Yeah, and it can be frustrating, our line of work. Well, Rhonda, I want to thank you so much for this conversation. I want to thank you, the audience, for listening. And for more information on more of our educational offerings, such as podcasts, live meetings, and so on, please go to our website, which is neiglobal.com. This is Dr. Andy Cutler. Rhonda, thank you so much for joining us.
Thank you.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.